In this lecture, Lecture 3 of the Practice of Cardiac Sonography 2 unit, the assessment of valvular function will be introduced. The contents of the lecture include 1. A review of valve anatomy and function, and of the principles used to make quantitative measurements of valve function. 2. Measuring aortic valve function. 3. Measuring mitral valve function. And 4. Measuring tricuspid valve regurgitation. There are 3 learning outcomes for this lecture. Following the lecture, you will be able to 1. Describe the principles and techniques used to measure valvular function. 2. Demonstrate the methods used to measure different stenotic and regurgitant lesions. And 3. Apply knowledge of measurement methods to grade stenotic and regurgitant lesions. Chapters 11 to 14 of Essential Echocardiography are the chapters you'll need to refer to for more information. Firstly, a review of the anatomy and function of the heart valves and of the principles used to make quantitative assessments of their function. The heart contains 4 valves, and the valves are anchored via their annuli, which are part of the cardiac skeleton. The aortic annulus and aortic valve are at the center of the cardiac skeleton, and its fibrous extensions join each of the other 3 valves. The 4 heart valves are situated at each end of the 2 ventricles. They are the 2 atrioventricular or AV valves and the 2 semilunar or VA valves. With echocardiography, the leaflets of normal heart valves appear thin and mobile. The annulus and subvalvular apparatus of normal valves are similar in brightness to the surrounding tissue. And normally, valves open fully to allow blood to flow through them and close tightly to stop blood from flowing backwards. If disease affects the heart valves, it may result in obstruction to blood flow, reverse blood flow, or both obstruction and reverse flow or regurgitation. As you know, obstruction to flow is termed stenosis. It's characterized by incomplete valve opening and a reduced orifice area. You also know that reverse flow of blood across a valve is termed regurgitation, and it's characterized by incomplete valve closure, resulting in a regurgitant valve orifice. Most often, disease that affects the heart valves is acquired. Less often, congenital disease results in valvular dysfunction. Both acquired and congenital disease can cause stenosis, regurgitation, or both. And the image at the bottom of this slide shows an aortic valve with signs of both stenosis and regurgitation. Pressure gradients occur whenever there is a connection between heart chambers and occurs with all regurgitant or stenotic lesions. The modified Bernoulli equation is used to estimate gradients, where the velocity squared and multiplied by 4 equals the peak pressure gradient. This measure does not give us the actual pressure of either chamber. It simply gives the pressure difference between the 2 chambers at a certain time. If the velocity of blood flow is known, the distance that a set volume of blood travels can be calculated. To estimate this volume, a point of reference is identified, and the cross-sectional area of the reference point is measured. It is assumed that these reference points, such as the left ventricular outflow tract, are circular in anatomy and that their diameter enables the accurate estimate of their cross-sectional area. Because the velocity of flow is constantly changing in the heart, the velocity time integral is used to calculate the velocity of blood flow at the point of reference. So the volume of blood flow can be calculated by multiplying the velocity time integral of blood flow with the cross-sectional area at specific sites within the heart. The continuity equation is routinely used to estimate valve area, especially the aortic valve area, to help determine the degree of stenosis. This measurement is based on the conservation of matter, that is, that the blood volume leaving the left ventricular outflow tract equals the volume passing through the aortic valve. The three measurements a sonographer needs to make so that the machine can calculate the aortic valve area using the continuity equation are: 1. The 2D left ventricular outflow tract diameter, 2. The left ventricular outflow tract VTI using pulse wave Doppler, and 3. The aortic valve VTI using continuous wave Doppler. This calculation relies heavily on the accurate measurement of the LVOT diameter. A small error in measurement is magnified in the calculation because a single linear measurement is used to estimate a cross-sectional area. There are limitations to the measurements we've reviewed, and these are listed on this slide. The two limitations that require the most careful attention as a sonographer are the conduit diameter and the Doppler beam alignment measurements when making measurements using the continuity equation. This introductory lecture does not include a complete list of all measurements of valvular function. Moreover, measurements of pulmonary valve function are not described. During the lecture, I will refer to the course reference values document. Page 3 of the document is shown on this slide. More measurements of valve function, including measurements of pulmonary valve function, will be part of units in the second year of the course. Measuring aortic valve function. Aortic stenosis. Aortic stenosis is characterized by obstruction of blood flow through the aortic valve. Aortic stenosis may occur because of an acquired or congenital abnormality. The most common acquired cause is calcific degeneration, and the most common congenital cause is a bicuspid aortic valve. The signs and symptoms that accompany aortic stenosis include left ventricular hypertrophy, which is an early compensatory response to increased afterload. Subtle signs like reduced exercise capacity and dyspnea. Symptoms such as angina, or, in more advanced cases, syncope or heart failure. A systolic ejection murmur is a common feature of aortic stenosis and a frequent reason for requesting an echocardiogram. 3 measurements should be used for all patients with aortic valve stenosis. The measurements are, firstly, the peak aortic velocity in meters per second with CW Doppler. Secondly, the mean valve gradient in millimeters of mercury with CW Doppler. And thirdly, an aortic valve area in centimeters per second using the continuity equation with the necessary 2D, PW and continuous wave Doppler measurements. In 2017, the European and American associations published ranges that are indicative of the severity of aortic stenosis. That is, ranges that indicate mild, moderate, or severe disease for the three values we've been considering. And these values are part of the course reference values document. One point about the recommendations is that an overall severity grade should be based on a combination of all three measurements. To recap, the three measurements needed to calculate the aortic valve area using the continuity equation are the 2D left ventricular outflow tract diameter, the LVOT VTI using pulse wave Doppler, and the aortic valve VTI using continuous wave Doppler. Aortic regurgitation. Aortic valve regurgitation occurs because of a structural defect in the aortic valve and results in the reverse flow during diastole. Aortic regurgitation may occur because of cusp or aortic root pathology, that is, aortic root dilatation. Aortic regurgitation may be central or eccentric. The image on the left of this slide shows central aortic regurgitation due to aortic root and ascending aorta dilatation. The image on the right shows eccentric aortic regurgitation due to valve calcification. The signs and symptoms that accompany chronic aortic regurgitation include left ventricular dilatation due to volume overload that results from the regurgitation, heart failure with reduced ejection fraction, and a diastolic murmur, in contrast to the systolic murmur that occurs with aortic stenosis. As I mentioned, we won't cover all measurements of valve function in this unit. For now, we will only consider the specific and supportive measurements of aortic regurgitation. Specific measures include measuring the vena contracta. The vena contracta is the narrowest segment of the regurgitant jet immediately below the aortic valve. The measurement is made using color Doppler imaging from the parasternal long axis view. The other specific measurement is identification of aortic flow reversal in diastole. This measurement is made from the suprasternal or from the subcostal view using pulse wave Doppler to identify reverse flow in diastole. Supportive measures of aortic regurgitation include the regurgitant jet pressure half time and the regurgitant jet deceleration time. These measurements are made using continuous wave Doppler from the apical 5-chamber or apical 3-chamber view. As you can see on the images at the bottom of this slide, long pressure half time and long deceleration time measurements are indicative of mild aortic regurgitation, whereas short pressure half time and short deceleration time measurements are indicative of severe aortic regurgitation. The measurement ranges indicative of different grades of aortic regurgitation are as follows. Measurements indicative of mild regurgitation include a vena contracta width less than 3 mm, a pressure half time greater than 500 milliseconds, and brief early flow reversal in the descending aorta. For moderate aortic regurgitation, a vena contracta width between 3 and 6 mm, pressure half time between 200 and 500 milliseconds, and intermediate flow reversal whereas severe aortic valve regurgitation is indicated when the vena contracta width is greater than 6 millimeters. Pressure half time is very steep, less than 200 milliseconds, and when there's pan-diastolic flow reversal in the descending aorta. Measuring mitral valve function. Mitral stenosis. Mitral valve stenosis is characterized by diseases that change the anatomy of the valve and cause obstruction to blood flow. Stenosis of the mitral valve changes the valve's anatomy, which can be recognized by changes to its 2D echo appearance. The leaflets and subvalvular apparatus become thickened, the leaflet's mobility is reduced, the orifice area is reduced, and secondary to stenosis, the size of the left atrium increases. The European and American associations recommend that the following 2D and hemodynamic measurements be made to assess the degree of mitral stenosis. Mitral valve area using 2D planimetry or continuous wave Doppler, mean transmitral gradient, as well as measuring the pulmonary artery pressure, which increases as a result of significant mitral valve stenosis. "2D planimetry of the mitral valve area is often possible even with significant leaflet thickening. 2D planimetry involves identifying the maximal cross-sectional area of the leaflet tips from the parasternal short axis view in early diastole. To do so, it is necessary to pan up and down through the valve to identify the leaflet tips. Doppler measurement of the mitral valve area involves measuring transmitral flow from the apical 4 or apical 2 chamber view with continuous wave Doppler to identify the pressure half time. The mitral valve area in centimeters squared is calculated by dividing 220 by the pressure half time. This calculation is made by the machine once the pressure half time has been measured. Continuous wave Doppler can also be used to estimate the mean pressure gradient across the stenotic mitral valve by tracing the entire Doppler spectrum from the 4-chamber or apical 2-chamber view. Mitral stenosis causes an increase in left atrial pressure. This leads to an increase in pulmonary vein pressure, and with significant stenosis, it also leads to an increase in pulmonary artery pressure. For this reason, it is recommended that the pulmonary artery pressure be measured using the Bernoulli equation to estimate RV pressure and in turn pulmonary artery systolic pressure by sampling the peak tricuspid regurgitant velocity. Mild mitral stenosis is characterized by a mitral valve area greater than 1.5 centimeters squared, a mean gradient less than 5 millimeters of mercury, and a pulmonary artery pressure estimate less than 30 millimeters of mercury. Moderate mitral stenosis is characterized by a mitral valve area between 1 and 1.5 centimeters squared, a mean gradient between 5 and 10 millimeters of mercury, and a pulmonary artery pressure estimate between 30 and 50 millimeters of mercury. While severe mitral stenosis is characterized by a mitral valve area less than 1 centimeter squared, a mean gradient greater than 10 millimeters of mercury, and a pulmonary artery pressure estimate greater than 50 millimeters of mercury. Evaluating mitral regurgitation. Mitral regurgitation is due to a defect that prevents the mitral leaflets from closing fully. There are a number of diseases that cause mechanical impairment of one or more of the components of the mitral valve, including diseases that impact the leaflets themselves, that result in annular dilatation, or diseases that impact the subvalvular apparatus. Careful 2D and Doppler assessments can help to identify the underlying cause. For example, a dilated left ventricle and mitral annulus is likely to cause central mitral regurgitation, or posterior mitral leaflet prolapse is often the cause of an anteriorly directed eccentric mitral regurgitant jet. The density and shape of the CW Doppler signal of mitral regurgitation can help to determine the grade. Firstly, the spectral density. With mild mitral regurgitation, the regurgitant signal is far less dense than the forward flow signal. With severe mitral regurgitation, the regurgitant signal is dense. It may be nearly as dense as the forward flow signal. Secondly, the regurgitant signal profile. With mild mitral regurgitation, the signal is parabolic or tongue-shaped. With severe mitral regurgitation, the signal is triangular in shape. The vena contracta is the narrowest segment of the regurgitant jet immediately above the mitral valve, measured using color Doppler from the parasternal long axis view. The vena contracta correlates with the width of the regurgitant orifice. A vena contracta width less than 3 mm is supportive of mild mitral regurgitation. A vena contracta width between 3 and 7 mm, supportive of moderate regurgitation, and a vena contracta width greater than 7 mm is indicative of severe mitral regurgitation. This measurement is limited by the fact that the width of the color jet can vary in systole. Pulmonary vein flow. Normally, the pulmonary veins flow into the left atrium in systole and diastole. In the presence of severe mitral regurgitation, there may be flow reversal in systole. This measurement is also limited if there is eccentric mitral regurgitation. It may not extend as far as the right upper pulmonary vein, which is the vein most often seen with transthoracic echocardiography. Finally, some brief considerations related to evaluating tricuspid regurgitation. The tricuspid valve, like the other valves, should be imaged from multiple planes so that the mechanism of the regurgitation can be identified. Most often, tricuspid regurgitation is secondary, that is, it's related to right ventricular or tricuspid annular dilatation. Minimal tricuspid regurgitation is seen in most people, whereas moderate tricuspid regurgitation, or regurgitation that is more than moderate, is always considered pathological. Like when measuring mitral regurgitation, the density and shape of the continuous wave Doppler signal can help to determine the degree or the magnitude of the tricuspid regurgitation. The first image shows a tricuspid regurgitant signal that is less dense than the inflow and parabolic in shape. And this indicates that it's almost certainly no more than moderate. The second signal, the regurgitant signal, is more dense and triangular in shape, strongly indicative of severe tricuspid regurgitation. Tricuspid regurgitation, identified and measured with colour and continuous wave Doppler, allows sonographers to estimate right ventricular systolic pressure by applying the modified Bernoulli equation. That is, using the example on the screen, a peak tricuspid regurgitant velocity of 2.5 meters per second equates to 25 millimeters of mercury. What is important to recognize is that a high tricuspid regurgitant velocity does not necessarily mean a high or greater volume of regurgitation. So, in conclusion, well-established principles and different echocardiographic modalities are used to evaluate the various forms and degrees of heart valve disease. Knowledge of and application of different methods for classifying valve disease, the knowledge of the different positive and negative aspects of the measurement are essential skills for cardiac sonographers.